Okay, well, welcome everyone to today's book launch event of Medical Assistance in Dying in Canada, Key Multidisciplinary Perspectives, published by Springer International and co-edited by Dr. Jaro Kotalik and Mr. David Shannon. I have the pleasure to be the moderator for today's event. My name is Dr. Kristen Jones-Bonifiglio. I'm the director of the Center for Healthcare Ethics at Lakehead University. To begin this event that's hosted in Thunder Bay, I wish to acknowledge the original custodians of this land and pay respect to the elders, past, present, and future, for they hold the memories, the traditions, the culture, and the hopes of Indigenous people. I recognize that I have the privilege of living and working on the traditional lands of the Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. I also acknowledge and am grateful for relationships with other Indigenous and Métis people who have a history in this territory. I wish to also acknowledge that today is National Indigenous Veterans Day. This book launch event celebrates work that emanates from Lakehead University Center for Healthcare Ethics and the Northern Ontario School of Medicine University. At this time, I wish to give honorary mention and extend gratitude for ongoing support to Dr. Andrew Dean, the Vice President of Research and Innovation at Lakehead University, and Dr. David Marsh, Associate Dean of Research, Innovation, and International Relations at the Northern Ontario School of Medicine University. The year 2023 marks the 25th anniversary of the Center for Healthcare Ethics. And one of the most important aspects of the work of the center is the ongoing commitment to inviting people to have hard conversations in respectful ways, to consider a variety of opinions and perspectives on difficult contemporary issues. This is what we're here to do today. Quoting straight from the acknowledgement section of this book, and I quote, "Above all, it is with gravity and sensitivity that we acknowledge the thousands of Canadians and their families for whom MAid has been a central question in their lives, and for those who may one day confront this decision." This book is part of a series in the International Library of Bioethics, a series that comprises international and interdisciplinary volumes on foundational and practical applications of bioethics. Books in this series exploring meaningful ways to answer questions about how to direct technology to humans and other living things, how to deal with change and changing values, and ways to formulate new ways of thinking. Using the words of the book's editors, and I quote, "We hope that this work will stimulate ideas, provoke debate, and additional discourse, and lay the foundation for new and advanced research that will provide the answers many Canadians are seeking. We urgently advocate for thoughtful evidence, sound empirical research, and human sensitivity that will advise future MAid-related amendments, regulations, policy, and the inevitable review by the courts." Today, we have both book editors and a panel of 3 interdisciplinary chapter authors to share their perspectives on the contributions that this book makes to ongoing changes in our Canadian healthcare landscape. We will proceed with a few questions for each of our panelists and then open to audience questions through the question and answer box function at the bottom of your screen. Please feel free to type your questions at any time during the conversations, and we'll try to have as many as possible answered in the time that we have together today. So initially, I'll start with some introductions. This book is co-edited by 2 significant authors in the field, one a lawyer and the other a medical doctor, both having elaborate careers in defending the rights of dying patients and those with physical or mental disabilities. This book has about 50 contributors across 13 universities, a wide representation of people who were already actively involved in public discussions about MAid across our country. First, I'd like to introduce Dr. Jaro Kotalik, a professor at NOSM, an adjunct professor in the Department of Philosophy here at Lakehead University, chair of our executive committee and founding director of the Center for Healthcare Ethics. Between 1974 and 1994, he served as a radiation oncologist and later CEO of the Thunder Bay Regional Cancer Center. and Vice President of Cancer Care Ontario. He served as an executive member to the National Council on Ethics and Human Research and a member or chair of several research ethics boards and committees of the Royal College of Physicians and Surgeons. In his capacity as a consulting bioethicist, he has provided services to Health Canada, the Public Health Agency of Canada, the Swiss National Advisory Commission on Biomedical Ethics, and other organizations. Also, as co-editor, we have Mr. David Shannon. David is a member of the Law Society of Ontario, practicing health law in Thunder Bay. He received a Master's of Law degree at the London School of Economics and has continued his law practice and non-governmental organizational leadership since then. His Dave Shannon Cross Canada tour in 1997 gained national media attention as he became the first quadriplegic to trek across Canada in a motorized wheelchair. And in 2009, he set another first by going to the North Pole, celebrating the message that seemingly insurmountable barriers can be overcome. He has won numerous prestigious awards and honors, such as the Order of Ontario and the Order of Canada. His academic and professional body of work has been expansive within the realm of human rights and health law. David has also been a sessional lecturer at Lakehead University and Algonquin College. Also on our panel, we have Dr. Ryan Tompkins. Ryan earned his PhD in philosophy from York University in Toronto in 2012. He is a bioethicist and researcher at Lakehead University Centre for Healthcare Ethics and NOSM University. He is an associate professor in bioethics and philosophy at NOSM University, and he is an adjunct professor in the Department of Philosophy at Lakehead. The scope of Dr. Tompkins' research in theoretical ethics, applied ethics, and bioethics is wide, including topics in reproductive ethics, ethics of artificial intelligence and robotics, ethics of human gene editing, and ethical issues in the context of organ recruitment and transplantation. Next, we have Dr. John Scott, an associate professor of palliative medicine, Department of Medicine at the University of Ottawa here in Canada. He assisted Dr. Balfour Mount in developing the first palliative care unit at McGill University in Montreal. He is trained in medicine, theology, and clinical epidemiology. Dr. Scott pioneered the Division of Palliative Medicine at the University of Ottawa, in which he continues to practice. And last but not least, Dr. Harvey Schipper brings a broad, multidimensional understanding of medicine as a whole, with experience in navigating sensitive public health policy issues, such as the tainted blood crisis of the late 1990s. He has written, spoken, and advised patients, professionals, institutions, and governments. He is an oncologist, professor of medicine, and adjunct professor of law with the University of Toronto. Initially trained as an engineer, he's also worked with the World Health Organization, where he helped shape pain control and palliative care programs across the world. He was at the forefront of patient-centered cancer therapy, introducing quality of life benchmarks for treatment development and evaluation. And he currently works at St. Michael's Hospital in Toronto. So with that, I would like to start our question and answer period with Dr. Jaro Kotalik. Jaro, I wonder if I could start with really a simple question. When people hear about this book, do they ask you, is this book for or against euthanasia? And how do you respond to that?
Well, I would say that anyone who opens the book will soon discover that this book is neither for nor against euthanasia and assisted suicide. Each chapter of the book has its own perspective, but they set out to examine the MAid program as has been performed for the last 5-6 years, and trying to make fill the big gap. It was in the end of 2020 when David and I realized that in spite of many discussions at various levels, there has not been any comprehensive publication at a scientific level which would examine the whole program. And so we have set out to fill the gap. And we were very lucky, as you noted, to be able to put together an outstanding team of the people of a variety of professions. A small sample we have today with us, and we hope that this will stimulate other writings and discussions on the topic.
That's great to hear. Sounds like it's very much needed, especially at this point in time. Now, here's a bigger question. How could we evaluate a complex, large program like MAid?
Yes, with interdisciplinary work, this is always a big issue because every discipline has certain standards, how they look and evaluate what's going on. But we thought that reading late in that should be directly in the MAid law. Bill C-14 is providing us with preamble, which articulated actually several expectations or promises which goes along with approval of the bill. And I'm sure this is the kind of thing which affected our parliament when they faced the issue of approving or not the law. And so I think it is something we need to be mindful of. So, so one of those promises is that, and I quote that, is to recognize the autonomy of persons who have incurable medical condition that causes them intolerable suffering and who wish to seek medical assistance in dying. Well, once the law was approved, government set up very quickly publicly funded facilities in all health centers across the country and made this program as a high priority because the access to MAid was recognized as a right for Canadians. As an outcome, we had very quick uptake of people into the program, and we found that when you look back and demonstrated in our book, only 4 out of 10 people are generally found to be ineligible. So the great preference is given to persons' autonomy. And that was delivered on average in 5 to 7 days after application. So given that we have a system in which people wait for family physician maybe several weeks, and for cataract surgery several months, and so it is remarkable that we have one service which in fact may provide intervention within days. So a number of MAid provision increased every year by about 30%, and by the end of 2022, we had over 45,000 MAid deaths. So we can say that that promise to respect people's autonomy at a certain situation was certainly fulfilled by the program, and which turned out to be a great administrative organizational success. But then there's that other promise made in the law, which was to strike the most appropriate balance between the autonomy of the persons who seek medical assistance in dying on one hand, and the interest of vulnerable persons in need of protection, and those of the society on the other. The balance was to be achieved by permitting access to MAid only to competent adults whose deaths are reasonably foreseeable. Well, this criterion was working for the first few years, but then at 2021, by Bill C-7, this criterion, which was supposed to provide that balance, was eliminated. And people who have progressive and incurable condition that who could have entirely normal lifespan, for example, people with arthritis, became eligible. So it is a question how this balance is maintained or should be maintained under those conditions, which we try to cover in the book. And the last promise I will mention is that Vulnerable person must be protected from being induced in moments of weakness to end their life. So it says not only has to be not persuaded and pushed to MAid, but should be even protected. Yet we know, and probably everyone on the line would realize that there has been numerous reports in the media about people who have been induced by someone or forced by difficult circumstances, medical, social, economic condition, or lack of care to go for MAid as the only solution actually left to them. The problem is that these news are generally ignored on the official level and is never investigated. And Health Canada reports never records any cases where the people who would be received MAid actually were not ineligible, for example, because they were under pressure or persuasion, external pressure, which would invalidate their consent. So we have this. We have to conclude that MAid program really failed in delivering on this promise, and our book is documenting that.
Thank you, Jaro. It's very important that the decision making is evidence informed. I'm wondering, now that the book is available in libraries and in the hands of the public, how will you know if it has achieved the goal that you and David maybe had set out when you first started writing it?
Well, I guess only time will tell. I mean, I think we have succeeded in putting together the team, which but that was initially thought to be insurmountable task, given how all these professionals are busy in their own books and lectures and everything, research and so on. But we managed to do that. Everybody delivered the chapters. They were read and reread by their colleagues. So we work really as a team. So that was a successful part. Now the book is out, and we have to see. I mean, we know that 550 pages book is not easy to absorb. And but what we do have in the book is that we have summaries, and we have quite often recommendations which are arising from that particular disciplinary approach, and also suggestions for research. So we believe that there is enough in the book for just about everyone to find it worthwhile to look into it. So I think that I'm happy to say that the books are available in Thunder Bay libraries, and hopefully in the hands of some of the professionals as well. Thank you.
Yeah, and it's so wonderful to have it all in one place. Many people trying to understand these issues from multiple perspectives. And Jaro, given your special interest in the monitoring of MAid and public reporting, do you have any key findings that you'd like to share with the audience?
I think that we should realize that right from the beginning of the program was recognized that the monitoring and reporting is essential, absolutely essential. And regulations were set up to make that possible in terms of data collection. But when we look back, we can say that so far monitoring has been very rudimentary, and reliability of it is very uncertain. I just make 2 points, but there could be others to make. So on one side, we have a monitoring which relies entirely on self-reporting. So however conscientious physicians are, they also dislike paperwork, and hospitals have quite often great difficulties to get them to complete their charts. So that one has to be worried that physicians who come to, or nurse practitioner who provided MAid have now 30 days to fill a form which they will find online on Health Canada portal may be incomplete. Our physician may forget, or they may not have at that time actually available all the data. Data being collected are intentionally those which was taught to physician can actually remember and report on without reviewing the chart of the patient. So, so we don't have any system to remind the physician to do that, unless actually each of them individually set up some process for that. But we don't know about that. So there's a concern: are these figures which Health Canada reports actually entirely correct, and could be missing some data? It could be clarified if the reports from pharmacists will be compared with reports from practitioners. Well, Health Canada tells us in the last report, for example, that they are comparing that, but they don't tell us how they agree with each other. And they don't tell us if there is a disagreement, if it is a 0.5% or 10% of the patients are not reported in the same way from these two sources. So this is one worrisome aspect of that. And we have some suggestions in the book, particularly that should be some kind of a on-site review and random selected cases across the country, which would check the chart and actually verify if the reports are there, was the consent obtained and signed, and so on. The other one other point is that MAid is possible as an exception from the criminal code, and MAid that is legal only if all the eligibility criteria and safeguards are fully respected. Now, this questions in the survey I talked about, which practitioners have to report for Health Canada, are asking about those safeguards and eligibility criteria. But because there is no other check on that, it would be desirable that, because this is a criminal law, that we know for sure that criminal law was respected. Now, Health Canada declared that monitoring of adherence to the criminal law is not their responsibility. As for other criminal law transgression, it is provincial and territorial government who have responsibility. So Health Canada says go to them for verifying that the criminal law was followed. On the other hand, however, provincial and territorial governments, with exception of Quebec, do not provide any reports. If they're doing actually any reviews of those reports, and if so, what the review is showing. So this is a big deficit, I think, in our monitoring. So thank you for your questions.
Thank you very much, Dr. Kotalik. You've done a wonderful job highlighting a number of the gaps that currently exist. Next, I'll turn to Mr. David Shannon. David, your chapters look at the legislative, regulatory, and jurisprudential developments of MAid safeguards. What are your main concerns, and what can be done to alleviate some of these concerns?
Well, Kristen, you articulated so well, I thought, one of the central intents of our work, and inspirations and motivations, and that is that we were very aware and concerned with sensitivity to the gravity of the outcome of the MAid program, the importance to its impact in Canada, but in particular the importance of its impact to individuals making these decisions and their families, their loved ones, their own micro and macro community. With that in mind, and Canadians have certainly, in the context of all questions of death, have taken this most seriously. That's motivated us, and also the tension of found within the debate, one of perhaps the extremes, or the most extreme of autonomy of choice, and the importance of adherence to the principles of liberty, or respect for liberty and individuals' liberty, while at the same time, whether the question of equality and the social contract is adhered to, in other words, the promises of the Charter of Rights and Freedoms. Do we have equality, or do we have social disenfranchisement driving the question? Because to be disenfranchised may mean people are suffering due to social determinants of health, rather, and that is negatively influencing the choices. And therefore, as Canadians, we would want to see social or economic impacts being reduced and or irrelevant to such brave choices. With that said, within that tension, that conundrum, we note that in the case, the Supreme Court of Canada case of Carter, which did establish the right to MAid, and I would emphasize that case, it was a right to MAid in a very limited fact-specific situation, but the Supreme Court noted that we should not lightly assume that the regulatory regime will follow defectively, nor should we assume that other criminal sanctions against the taking of lives will prove impotent against abuse. And because there was a concern that there's not enough safeguards. So the question contemplated by several authors, and one of the chapters I prepared was the question of, are there enough safeguards? Is the Government of Canada and then delegated authority to the provinces, have they met that lofty objective of meeting the regulatory regimes? Well, we note that there has been some regulations passed, but key within authors and recommendations are that regulations still need to differentiate between what we now know as is called a two-track system. One is for persons with whom death is naturally foreseeable, or in other words, imminent. Other persons who have a disabling condition or a chronic condition, but may have several years to live. That second track, the track 2 system, it's only a 90-day waiting period, when all of the literature with respect to psychosocial adjustment for disability points more toward a one-year adjustment period, and therefore regulations that would protect or safeguard a person in their emotional and psychological adjustment to disability or catastrophic injury should be respected, and it should be empirically based, not a legislation driven by an arbitrary number called 90 days. Also, within the legislation itself, it's very wordy, but it does look at a couple of keywords. One is, if the condition must be irremediable, that disabling or medical condition must be irremediable. There's much ambiguity around it. The courts have avoided a specific definitional interpretation, instead deferring it to what's termed the corpus of medical knowledge. Secondly, the question is of suffering, and what is the definition of suffering that is intolerable to the individual? As a lawyer, we play around with words and definitions, and spill a lot of ink and a lot of hours in court on those questions. The view of many authors is that it still remains ambiguous, and it's important to further flesh that out or have it defined by the courts. Key, as I've already noted, but worth emphasizing, is there should be protection for individuals through public education, housing supports, education supports, and certainly safeguarding of vulnerable individuals against any form of coercion, or even, I emphasize, non-intentional or just perceived suggestion or inducement toward MAid, because we are dealing with persons in a very vulnerable and very sensitive time in their life. We also strongly urge further funding and support for suicide prevention and palliative and home care. You've heard Jaro mention a multidisciplinary approach. That is key. In addition to assessments and decisions being made exclusively by physicians or nurse practitioners. There's several other areas of expertise, such as social work, disability rights experts, and other disciplines who would bring much to contribute to the improvement of regulations and also to oversight and monitoring. Lastly, as I say, oversight and monitoring, I don't have much time to go into this at length, but I do note that in the case of Sorensen, a case of the Nova Scotia Court of Appeal, while indicating that courts do not have the ability to, on a case-by-case basis, deal with all the MAid cases that could come before it, they don't have the institutional capacity. They did leave the door open for provinces to set up administrative review and/or tribunals. This is well established, certainly in Ontario law, with several social and health-based tribunals. It would be appropriate to have one, certainly to monitor MAid, such that they may be able to receive reports on an annual basis, report to the minister, and also where there is a question of inducement toward MAid during a time of vulnerability or other flaws in the assessment process, that those could be reviewed by an arm's length, I emphasize it would have to be arm's length, independent body that is quasi-judicial in nature and apolitical. Thank you.
Yes. So you spoke about the need for safeguards, and I know that you have been doing work in the field of health law with a special interest related to mental health and psychiatric care for many years. I'm wondering, what does your experience tell you about the provision of MAid for groups with vulnerabilities such as mental health issues?
Yes, and I have to say, well, first, we are very rapidly approaching a very critical date in the legislative calendar, and that is March of 2024, just a little over a few months away. The current Criminal Code of Canada will be simply adopted right now to include mental illness as a criteria for part of one criterion for MAid. In other words, persons with chronic mental illness will be able to seek MAid unless there is an amendment to the current legislation. In my review, I'd like to also note co-authors in the chapter that I wrote are Alexandra Giancarlo of the University of Calgary and Elaine Toombs of Delico Anishinaabe Family Care in Thunder Bay, and also a lecturer at Lakehead University. We found that it's premature, that it would make, at this point, the expansion to mental illness as part of the criteria for MAid is premature. It also runs counter to established legal principles. Now, I also mentioned a certain bias. This year marks my 25th year in appearing before the Consent and Capacity Board as legal counsel for patients who are certified under the Mental Health Act and/or have been deemed incapable of consenting to treatment or also accessing long-term care under the Healthcare Consent Act and also the Substitute Decisions Act. So I have a certain interest and experience in the field, and I find that, or would be my conclusion, that in addition to it being premature, that in that tension I had indicated earlier, that tension between autonomy of choice and one of protection for persons at a time of vulnerability, this certainly falls squarely into the question of mental illness and in particular, is a person seeking MAid at a time of mental disorder. We don't do that within our legal framework. We don't do that to persons who are suffering mental illness. We don't, for example, we don't find a person criminally responsible if they're suffering mental illness. And we certainly, I would submit, do not and should not allow them to have access to MAid, should there be the possibility of, in fact, this is better dealt with as either a matter for suicide prevention or medical treatment of their mental illness. And certainly within the clinical standards, I'm not a clinician, within clinical standards, there is a strong body of literature to point toward many forms of mental illness being remediable. So if a person's suffering due to mental illness can be remediable, we believe that MAid should not be the answer. I wish to further emphasize that it's well-established law under the Mental Health Act and the Healthcare Consent Act, decades of law in Ontario, all of Canada, and jurisdictions around the world, where should, within the context of mental illness, that the state does intervene. They intervene at a time when a person is not just vulnerable, but where they are at a safety risk to the public, at a safety risk to themselves, at a risk of imminent mental or physical impairment. Of course, this falls squarely into the question of MAid, where it's central to MAid is the question of self-harm. It's well-established law, the state intervenes. If a person presents at emergency with a mental disorder that might put them in a vulnerable position to experience personal harm, I do truly believe that while there is a place for autonomy and choice in treatment, that we don't provide a form of medical intervention when in fact it's more appropriate to have the prevention as one of safety for the public, safety for the individual, and adheres to the well-established law. And therefore we should not rush to just flip that law upside down without a deeply considered impact for what that will say for Canada and for the potential unnecessary loss for life within Ontario and Canada.
Thank you so much, Mr. David Shannon, for helping us understand a bit more of those legal aspects and the need for safeguards. Next, I'd like to turn my questions to Dr. Ryan Tompkins. So Ryan, as a bioethicist for the Center and for NOSM University, you're drawing people's attention to ethical issues that occur in every aspect of healthcare. What are some of the main ethical issues that you've identified on the interface between MAid and organ donation?
Could I just start, Kristen, by saying thank you to Jaro and David for including me in this book, and very excited to be part of this panel today. And thanks everyone for joining us for their lunch hour. My chapter was on looking at some of the ethical and philosophical issues at the intersection of medical assistance in dying and deceased organ donation. As much as I could do in 6,000 words, right? So this is something that is getting a bit of attention in the academic literature, but certainly much more needs to be done, and that's part of the main conclusion of my chapter. Further research needs to be done at the intersection of those two topics, but maybe a couple of the key findings. I think that's what your question's asking, Kristen. One is, if we are assuming that MAid is legally permitted, which it is in Canada, and if we're assuming that deceased organ donation is also legally permitted, which is in Canada, I didn't identify any inherent ethical concerns with the combination of those two practices. So again, as much as you can in 6,000 words, the conclusion is any of the ethical issues that identified were about how we orchestrated in practice rather than something inherent to the combination of those two things. One of the things that I did as a philosopher, this is my background, philosophy, interdisciplinary approach to this topic, was to challenge some of the assumptions that I identified in the nascent literature in this area. One of the assumptions that I saw coming up often is that the request for organ donation should never come before the request for MAid. It should always go the other way around. And so part of what I've done in this chapter is to motivate further inquiry into challenging this assumption and ask if there's ever any circumstances in which it's okay, morally speaking, for the donation question to come before the MAid. One of the examples I give is if you have someone that's been a lifelong registered organ donor through their licensing, that then requests MAid, it's unrealistic to say that they shouldn't be eligible for MAid if they meet all the eligibility criteria just because they've been a registered organ donor for their entire adult life. So just to challenge that assumption. Another one that I saw in the literature, and I'll keep this brief, I know there's other panelists, another major assumption that I saw in the literature was about never should it be the case that a person's reason for requesting MAid is because they want to be a deceased organ donor. And so, again, not coming to any conclusions, but challenging that assumption. The argument that I present is something like, if someone really does meet all of the eligibility criteria, I won't go through those, but if they really do meet all the eligibility criteria, I can think of at least some cases where it would be morally acceptable for that person to choose to pursue MAid for the purpose of donating their organs when they're deceased. One example I could think of is if they have someone that they know that is out of the blue come in need of organs and isn't getting the organs that they need, for that person to then decide to choose MAid for that reason. Again, assuming that they meet all the eligibility criteria, can't make it clear enough, not concluding that this is the way it should be, but to challenge some of those assumptions that I'm seeing in the literature. I think that answers your question, Kristen.
Absolutely. And just in terms of those assumptions, I'm wondering if you might share with us, what do you think about the motivations of people to ask for MAid in order to be able to donate their organs?
Are you asking if I think that it's morally acceptable for them to choose MAid for that reason?
Just wondering what your thoughts are in terms of some of the motivations, why people might ask for MAid, and whether maybe we don't know the answer to that, and maybe it's part of our assumptions and we really need to look for some facts.
Yeah, I don't. So I think the answer is going to be dependent on the particular person. I don't think there's a one size fits all reason. I should say I did reach out to the organ transplant coordinator or organ donation coordinator at the Thunder Bay Regional to ask how many cases has there been so far of deceased organ donation after MAid, and they've told me that there's been 3 since 2016, and all of them were not directed donations. So they were deceased organ donations, but going to strangers essentially. So that's interesting to hear. Why would those people be motivated? We often hear wanting to do something sort of useful or altruistic at the end of life. I would expect that we'd see the similar reasons emerging in the context of MAid and deceased organ donation as well.
Thank you so much, Dr. Ryan Tompkins. I think your chapter is an excellent example of the breadth and the depth of this particular book, looking at very broad issues, and again, bringing us back to looking at the data in terms of understanding MAid in Canada. I'd like to turn next to Dr. John Scott. I'm wondering, as a physician specializing in palliative care, can you tell us from your own perspective how MAid may have affected palliative care in Canada?
Yes, hello. Great to join you. Canada really has made an amazing and rapid, huge investment in rolling out MAid over the last 8 years and expanding it. And there were hopes that that would be accompanied by a similar investment in palliative care. But from our perspective, and I think the evidence is there, that accompanying investment in palliative care has not occurred. And in fact, there is a growing set of evidence that in fact there's been some diversion of existing palliative care resources into MAid services, thereby decreasing palliative care access. I mean, we know already that many Canadians do not have access to specialized palliative care services, and the kind of collapse or problems with our primary care system in Canada means that even access to very basic primary level palliative care is often missing. So that's a problem. And probably more importantly from our point of view is how the MAid issue dominates the airways and dominates the conversation nationally. So it's not that palliative care is trying to fight or oppose MAid, but we're wanting to change that conversation and say, let's not put all of our energy and talk into the 5% who at the very end make this particular choice, but let's look at what we need for the 100% who need palliative care as part of their dying process. The impact is hard to even measure at times, how both positive and negative. But one of the things that I see is a misunderstanding of what natural dying is about. And example, the last 5 years, the number of times I've had angry families at the bedside of, let's say, a 90-year-old dying slowly but peacefully without any symptoms, and the family are furious because there's no way to hasten it, and they demand some sort of hastening of the death, because to them a MAid death is the only dignified death, a quick death. They feel that dying is useless and is somehow undignified in itself. And that's a change in the Canadian way of looking at the dying process. And so it's one of the many hard to measure impacts of what was seemed like a simpler issue at the time. Certainly legislation tells palliative care that we're part of the safeguard. We are the alternative that must be asked about or even offered in the case of the Track 2 patients. And that role, I think palliative care is very comfortable in providing that. The problem has been that as the regime has been rolled out, there's this increasing pressure that we no longer are distinct from MAid, that we somehow become rolled into the MAid delivery system. So our beds, the few beds that we do have in the country for hospice palliative care, we're being forced by governments to utilize to have patients sit there to wait for MAid. And we also have a number of other ways in which our services are being pushed to put it together. We think it's better for the patients for palliative care to be distinct so that we can constantly put our focus on looking at suffering, offering various ways to relieve and comfort. And so that would be certainly one of my answer to that question.
Thank you. And we're talking a lot here about patients' choices, but I'm wondering about some information from a practitioner's perspective. So in our MAid law, the physician or nurse practitioner can find a person eligible for MAid only if they have an enduring suffering that is intolerable. How can a practitioner actually determine if a patient's experiences are enduring and intolerable?
Certainly my experience and my reading of the literature is that there is no effective way of doing that. The way the legislation is actually written the number of qualifications over that, it really, the suffering becomes a code word for autonomy. If the patient says they have intolerable suffering, then the physician or nurse practitioner checks the box of suffering. In many other permissive jurisdictions like Netherlands and Belgium, the physician must agree that suffering is enduring and intolerable. That does not occur in Canada. The legislation does not require it, and it's definitely not being viewed as essential in Canada as it's practiced. So it doesn't matter whether the assessor or provider thinks that suffering is endurable or unbearable. It is the patient's decision. And there's a lot of language in the legislation that gives you this sense of this is for last resort, very severe situations. But in fact, it doesn't play out that way because of the qualifications in the law.
You highlight some very important differences between countries that I think it's really valuable to be aware of when we're comparing and contrasting. One further question, I'm wondering about in your bedside experience with patients, why do people ask for MAid?
It goes back a bit to David's comment about and Jaro's too, about MAid reports. The information about why someone has asked, that is reported in the MAid reports, the annual MAid reports, coming from the providers, the ones who give the MAid injection, is very much out of whack with patient-derived literature on this. And I would say that the literature matches with what I observe at the bedside, which is the most important thing is actually the fear of future suffering. That most patients are actually are more worried about what's going to happen. They feel they've become convinced that their death is going to be scary and undignified and painful, and they want out now before this happens. A fear of the dying process, sometimes not based on what those of us who have watched thousands of patients die would believe is the normal way of natural death. And that's one thing, any of you who want, for your own sake, but also patients' sake, look up YouTube on Catherine Mannix, M-A-N-N-I-X, who does a marvelous job. She's a palliative care physician in the UK and does very effective work in teaching the public what is normal, natural dying look like. Because that we need to have people understand what that looks like before they can make an informed decision about whether they would want that as opposed to MAid. So, I mean, we even see the Gloria Taylor, the first person allowed by the BC Superior Court to have assisted death, who didn't end up, 4 months later, died of another complication, not of ALS or qualifying illness, not by MAid, but by another complication. She actually wasn't in unbearable suffering at the time she was awarded this. It was her future fears, and her documentation shows that. It was about what she imagined dying was going to be like. I mean, I'm not saying there aren't patients who are not suffering right at the moment, but again, the other fact of that is that, again, the literature that is patient-derived, based on qualitative research, confirms what I see. And it's not about their pain or their other physical symptoms or their illness. It's about internal, psychological, social, and existential factors that first are not stable. They change, and they change unpredictably, and they respond to support and therapy. So to be able to say this is not remediable is not what a physician or other practitioner or other caregiver can say. So that becomes a definite problem. I have no trouble in constantly pouring out possible ways to relieve to patients who I see. Thank you.
Thank you, Dr. John Scott. I hear you saying is that we need to be having public conversations, back to basics, discussions, and a better understanding about things like human suffering and natural death and dying processes. So important and really foundational to our decision-making with MAid. So thank you. Last but not least, turn to Dr. Harvey Schipper. Very fitting, I think you wrote the concluding chapter in the book. So concluding this wonderful book launch, I'm wondering, with your experiences with this issue, and your chapter was called Death on Demand ? Having been a chapter author in this book, it must have left you with one or two overriding impressions, and I wondered if you might share those with us.
Thank you, and thank you all for inviting me, and to Jaro and David for inviting me to join in the production of the book, and allowing me to do the concluding chapter, because it forced me, if you will, to broaden my knowledge further than what it had been from reading a remarkable series of thoughtful presentations as they evolved. Let me provide just a tiny bit of background. It just so happens that in my career, I've found myself around places like the First Minister's table and the Deputy Minister's table in provinces and across the country on some very sensitive issues. Maybe the first one was the whole business of legalizing heroin a long, long time ago, and John will remember this, where what we were able to do under pressure, really from patients who were not having their pain adequately managed, a physician writing under a pseudonym, Dr. Gifford Jones, advocated for heroin because we weren't relieving pain. And what we came up with then was a scheme where initially heroin was legalized, but it was coupled with intensive investment in education of physicians about how to properly manage pain and suffering when people needed it. And it was a critical moment in the expansion of palliative care in Canada. John, you were involved, Balmount, Neil MacDonald, and I were all very much involved in that. And that was a very sensitive balancing of risks and benefits for the community as a whole. It wasn't spoken of as autonomy versus, Section 1 versus Section 7 of the Charter, but that's really what it was. And that was somewhat difficult. And then I found myself in the same position, policy making in the time of the tainted blood crisis. And for many years thereafter, people said to me, well, my goodness, that was the toughest bit of policy making you're ever part of. And they would say that consistently. And now I have a come back to that, saying this issue makes that look like child's play. Because this is not a technology issue. This is a social values issue. And it has been approached with one kind of way of thinking, which is legal thinking. And maybe one of the biggest lessons for me in this, having been involved everywhere from the bedside to in the House and the Senate, is that it's an argument that's made in legal language when in fact its execution is in an entirely different culture. That's a medical culture. And that law was brought forward through a legal process, in part because it was going to be very unlikely to succeed coming through a more traditional medical process. And so you have, in effect, a culture war between law and medicine around not a new technology, but a social value. And one of the fundamental questions for me that I've encountered across the country is how broadly is the social value that is expressed in this rapid expansion of MAid in Canada. And we are now on a population basis far and away the readiest provider of MAid. How widely does that social value, is that social value really represented among Canadians as a whole? And David and John have both kind of alluded to that. The people who advocate for it have a particular point of view, and they've been very, very successful working the political and legal process to make that happen. So that was one lesson. The other lesson comes from a philosophic principle that was introduced to me a number of years ago called the fence within the fence. And the notion is that there's some values, some ideas where you shield them because to even attack those fundamental ideas will open a Pandora's box whose consequences are much more than you would anticipate. And so what you tend to do around those issues is you put a fence around the fence. So, you know, for example, when we talk about ending people's lives, we have a fence around the fence where in the legal system, there's murder, there's manslaughter, there are all sorts of articulations around the fence, around the fundamental principle that you don't end someone's life. But once you puncture that inner wall, the consequences explode on you in ways you don't anticipate. And maybe the 500 pages of this book are a very good example of that. When Carter came forward, it was seen as a relatively straightforward notion. Someone at the end of life, nothing else was available, wanted to have their suffering ended in a humane way. And we had a very old technology. There's no new technology at all that could bring that forward. And then you open the Pandora's box and you discover, what are its implications for the disabled? What are its implications for the profession, the health professions as a whole? How is this perceived in the public? Do we anticipate people being so captivated by this notion of control about ending their lives, maybe so afraid of an undignified life, that they alter their life perspective because of this? And each of the chapters in this book, in a way, starts to question and unravel the much broader consequences of what is not a technological change, but a huge social change in the country. And I don't think we've really come to terms with that. So those are really the big lessons for me. And you compare that with Parliament facing a new technology, you know, a new airplane technology becomes available. And what do? We say, well, you know, we're going to have new airplanes, but we're going to do this very incrementally, very carefully, because we're not fully aware of what the consequences of this new technology are. So here we take an old technology and we suddenly wish to apply it very broadly, and we're not thinking about the consequences.
Thank you. I think framing MAid as a social values issue is a really key context that this book will bring to people's understanding and decision making. For yourself, I understand that you're not a MAid assessor or provider, but you do have clinical experience that you can bring to this topic. Your first entry into the debate about MAid suggests that you were opposed to it under any circumstances. I'm wondering what happened to change your mind.
Well, I actually didn't change my mind. And the editorial that I wrote in the Globe and Mail was widely read, and by MAid advocates was widely criticized. And the argument I made was that, firstly, I was concerned about the slippery slope. And a lot of the talk among advocates at the time said there's not going to be a slippery slope. It's going to be very narrowly defined. Well, now with Bill C-7, we see clear evidence of a slippery slope, and 45,000 deaths in Canada on a population basis, 10 times the rate of other places, suggests, whatever you want to call it, there's rapid expansion or a slippery slope. But the argument I made at the time also said the following. It's simplistic to think that the only suffering in question is that of the person who decides for whatever reason that they want MAid. There are knock-on effects to family, to the community as a whole. And one of the things I certainly see as a clinician, and I'm an oncologist and I'm quite familiar with palliative care, and I talk with patients all the time at times when they're looking at the end of life. One of the fundamental questions is, what is your value set and what happens to other people around you? The focus on MAid as purely an individual autonomy question is one form of autonomy. And it was built into the Canadian Constitution, in part historically because of the relationship of the church and others in Quebec. We wanted, less state involvement, more individual involvement. But there are other forms of autonomy, and one is relational autonomy, and that says something that happens to me affects someone else. So to give you some examples of this kind of thing, we've all seen the pain, the worry, the suffering of another sort that happens when a patient says to their family, I want to end my life. The other thing that happens often is fracturing of families over this kind of issue. And another phenomenon that I've seen more than once and started to write something about is something I've called maidism, where people who, as John says, are looking at the end of life become absolutely fixated on the notion of MAid. And I can think of one particular patient who was in her 90s, had, the rusty bumpers and things that go on with being around 90, but was basically healthy and alert. And from the day the Carter decision came down, she was fixated on MAid, to the point where she approached approval for MAid, was assessed by 2 MAid providers who actually never met her. It was all done over the telephone because of COVID. She was accepted, and she scheduled and canceled MAid 5 times. Why? Because she'd oscillate between this fixation on MAid and I've still got things to do. I've got grandchildren I want to be around. I have all sorts of things like that. In the end, she had a stroke and died within 24 hours. And MAid was brought in, but the distinction between MAid and palliative care then is moot. So the notion that the only people whose suffering is being relieved are those who are the direct requesters of MAid, I think needs to be balanced against, are we increasing suffering in another dimension? And I think there's an argument to be made, if you have a comprehensive social view of suffering, we may in fact have increased the suffering with MAid, with the relative provision of MAid. And to both David and John's other point, and particularly Jaro's, we've set up no mechanism to assess that. And so here we go on an ideologic issue, racing ahead at a great rate with something that is measurable, but for reasons what you might call political, we're not asking the critical questions. So I was never opposed. I just wanted to make sure we got it right.
Thank you very much, Dr. Harvey Schipper. I know a lot of audience questions have been answered through your thoughtful responses to my questions. I'd like to read out a couple of comments that have come through in the Q&A chat box. The first said, "This is a statement of gratitude and appreciation to the authors and editors of this important book. The book brings to light many of the critical questions and offers valuable suggestions for Canadians and lawmakers and clinicians alike. As one of the many chairs of psychiatry that are challenging Bill C7, MAid for the mentally ill, this book will be of assistance for years to come." Also, another comment, "I must commend the authors of this book and thank them for the opportunity to listen to their varying approaches to improving end-of-life care issues, including both palliative care and MAid. Thank you all for your efforts to educate the public and healthcare professionals on such critical healthcare issues. Keep up the good work." So I thank each of you so much for your contributions to this book and also to this book launch webinar. Like so many sessions with the Center for Healthcare Ethics, it feels like we're just getting started and it's already time to close the session. And I think, only time will tell Canadians whether or not MAid is a triumph of choice and autonomy or a national tragedy. And all of you have brought so many points of data forward in terms of informing our decision making and not only understanding these issues with our heads, but perhaps also with our hearts in terms of that connection with suffering and relationships. So on behalf of Lakehead University Centre for Healthcare Ethics and the Northern Ontario School of Medicine University, I thank all of the panelists and wonderful audience members for taking the time today to have this discussion and be part of this book launch event. Again, the book is Medical Assistance in Dying in Canada, Key Multidisciplinary Perspectives, published by Springer International and co-edited by Dr. Jaro Kotalik and Mr. David Shannon. Thank you, everyone. Take care. Have a wonderful rest of your day.
Take care.
Thank you all.